Meet Nadia, 29 years old, with Graves' disease, an overactive thyroid, and a few weeks ago she stopped taking her anti-thyroid medication. Then, this week, a flu-like illness. Now she is burning up, a temperature of 40.1. Her heart is galloping at 165, in atrial fibrillation, chaotic and fast. She is agitated, confused, drenched in sweat, her whole body in overdrive. This is thyroid storm, a hypermetabolic crisis, and here is the trap that catches people. It is not the thyroid hormone number that will kill her in the next hour. It is the fever and the racing, disorganized rhythm. Treat the number and wait, and you may lose her. Treat the storm in the right order, and you save her. 1 patient. 6 decisions. Let's take them. Step 1. Recognize the cues. Start in the nurse's notes. A young woman with a known overactive thyroid, off her medication, hit by an infection, and now decompensating across every system. Her temperature, her heart, her mind. Your job is to gather these findings and see that they form a single, life-threatening pattern, and to notice that the diagnosis here will be made at the bedside, not by a lab value. So move through every tab. The vitals, the labs, the orders, the history, and pick out the cues that tell you this is a storm. Open the Vital Signs tab, and this is where the emergency lives. Her temperature is 40.1, a dangerous hyperthermia. Her heart rate is 165, and it is irregular. Atrial fibrillation with a rapid ventricular response. The heart driven wild by thyroid hormone. Her breathing is fast, and her blood pressure shows a wide gap between the top and bottom numbers, a hyperdynamic circulation. And her mental status is deteriorating, agitated, and confused. Read these together. A raging fever, a chaotic fast rhythm, and a failing brain. That triad, not any single number, is the storm. Now the Labs tab. Her free thyroid hormones, T4 and T3, are high and her TSH is suppressed, as low as it goes. These confirm that she is thyrotoxic, profoundly hyperthyroid. But here is the crucial point, and it is easy to miss. These numbers do not tell you she is in a storm. The degree of hormone elevation in thyroid storm often looks no different from stable hyperthyroidism. The storm is defined by the clinical picture, the fever, the arrhythmia, the confusion, not by how high the hormone climbs. Her white count is up too, a hint at the infection that likely tipped her over. Now the Orders tab, and read it as a sequence, because in this case order is everything. First, a beta blocker, propranolol, to control the adrenergic storm, the racing heart, the tremor, the fever. Then propylthiouracil, to block the thyroid from making new hormone. Then iodine, to block the release of stored hormone. But notice the instruction, given at least an hour after the propylthiouracil, never before. Then hydrocortisone, acetaminophen, and cooling, and pointedly no aspirin, plus cultures and fluids. The orders encode the whole strategy. Finally, the History tab. She has Graves' disease, the most common cause of an overactive thyroid. She stopped her anti-thyroid medication about 2 weeks ago, removing the brake. And this week she developed a flu-like illness, the classic precipitant, because infection is the most common trigger that tips chronic hyperthyroidism into a full storm. She has no known heart disease, which tells you that racing, fibrillating heart is being driven by the thyroid, not by a primary cardiac problem. The history hands you both the cause and the trigger. Here are the cues that count. First, the hypermetabolic triad, a temperature of 40.1, a heart rate of 165 in atrial fibrillation, and a deteriorating mental status, agitation and confusion. Second, the setup, Graves' disease, off her medication, with a fresh infection, the perfect storm. Third, the confirmation, high thyroid hormones with a suppressed TSH, thyrotoxosis. And fourth, the lesson threaded through all of it. This is a clinical diagnosis. The storm is the systemic decompensation, and it will kill her long before the hormone number matters. Those are your cues, and they say, treat now. Step 2, analyze the cues. Many patients with Graves' disease walk around thyrotoxic, with high hormone levels, and are not in crisis. So the essential question here is not, is she hyperthyroid? You know she is. It is, has she crossed the line from thyrotoxicosis into thyroid storm, a decompensated, life-threatening emergency? So take each finding and sort it. Which of these would fit stable, chronic hyperthyroidism, and which mark a true storm? The answer changes how fast and how hard you act. Sort them, and the storm declares itself. A mildly elevated hormone level, on its own, is just thyrotoxicosis, something you treat, but not an emergency. But a temperature of 40.1 is not stable hyperthyroidism, it is hyperthermia, a hallmark of storm. A heart rate of 165 in atrial fibrillation is cardiovascular decompensation. Agitation and confusion are central nervous system involvement. And an infection as a precipitant is the classic trigger that converts one into the other. It is this constellation, the fever, the arrhythmia, the altered mind, driven by a trigger, that defines the storm, not the hormone value. And that means you treat clinically and immediately. Step 3. Prioritize. Name the one problem and the first action, and feel the pulls in different directions. One instinct says, confirm it first. Wait for the thyroid function tests before committing. Another says, shut the gland down, give iodine right away. And with a fever of 40, someone will reach for aspirin. Each of those is wrong, and some are dangerous. So ask, what is threatening her life in the next minutes? And what first action addresses that without making the storm worse? The priority is her life-threatening hypermetabolic decompensation, the racing, fibrillating heart and the soaring temperature, and the first action is to blunt the adrenergic storm, a beta blocker, propanol together with aggressive cooling. Here is why. The tachyarrhythmia and the hyperthermia are what kill in the near term, and propanol slows the heart, calms the agitation, and even helps block the conversion of thyroid hormone to its active form. Waiting for labs wastes time in a clinical emergency. Giving iodine first is a trap we will come to, and aspirin actually frees more thyroid hormone into the blood, worsening the storm. Name the decompensation and reach first for the beta blocker and cooling. Step 4. Generate the solutions. Lay out everything that belongs in the plan. This is select all that apply, and thyroid storm is treated with a coordinated set of drugs, each blocking a different step. To block the hormone's effects on the body, a beta blocker. To block the gland from making new hormone, a thionamide, propylthiouracil. To block the release of stored hormone, iodine, but only after the thionamide. To reduce conversion and cover a stressed adrenal system, glucocorticoids. And supportive care, aggressive cooling with acetaminophen, fluids, and treating the infection. Then the traps, giving iodine before the thionamide, and using aspirin to cool her. Gather the right agents, in the right relationship to each other. Here is the plan. Give a beta blocker, propranolol, to control the heart rate, the tremor and the adrenergic surge. Give propylthiouracil, a thionamide, to stop the thyroid making new hormone, and in storm it has the bonus of blocking peripheral conversion. Then, and only then, at least an hour later, give iodine to block the release of preformed hormone. Add glucocorticoids, hydrocortisone to blunt conversion and support the adrenal glands. And provide aggressive supportive care. Cool her with acetaminophen and external measures, replace fluids lost to fever, and treat the underlying infection. The traps are specific and important. Give iodine before the thionamide, and you hand the gland the raw material to make even more hormone. And aspirin displaces thyroid hormone from its carrier proteins, raising the free, active level exactly the wrong direction. Step 5. Take action. And here the sequence is not a preference. It is pharmacology. One agent controls the immediate cardiovascular threat and buys time. One blocks the factory. One blocks the warehouse from shipping, but only after the factory is shut, or you make things worse. And one supports the whole system. Sequence these the way the orders are written, and at each step, ask what this drug is blocking, and whether the step before it has to come first. Here is the order. First, propranolol, the beta blocker, to slow the racing heart and calm the adrenergic storm, alongside active cooling. This is your immediate life-saving move. Second, propylthiouracil, the thionamide, to shut down new hormone synthesis. Third, iodine, to block the release of stored hormone, given at least an hour after the propylthiouracil, never before, because iodine given first can fuel more hormone production. And fourth, glucocorticoids and full supportive care, cooling, fluids, and treating the infection that started it. Beta blocker, thionamide, then iodine, then steroids and support. The one sequence you must never break is iodine after the thionamide, not before. Step 6. Evaluate. You have given the beta blocker, the thionamide, the iodine in its proper order, the steroids, and you are cooling her. Now close the loop. And here, as with the hyperosmolar patient, the lab is the wrong place to look first. So reassess the storm itself. Is her temperature coming down? Is her heart rate slowing? The rhythm coming under control? Is she less agitated, clearer? And resist the urge to judge success by the hormone level, because that will not move for days. Ask, is the storm breaking at the bedside? Here is the reassessment, and it is good. Her temperature has fallen from 40.1 toward 38.2. Her heart rate is slowing, and the rapid atrial fibrillation is coming under rate control. She is calmer, more oriented, the agitation settling. Those three, the fever, the rhythm, and the mind, are the real measures, and all are improving, which means the storm is breaking. Now, her thyroid hormone level is still high, and it will stay elevated for days because the drugs stop new production and release but cannot instantly clear what is already circulating. Do not be alarmed by that number, and do not chase it. The bedside picture is your guide. Keep the agents going, keep treating the infection, and let the storm subside. Clinical improvement, not the lab, tells you she is turning the corner. Let's tie the case together. Your cues: a temperature of 40.1, a heart rate of 165 in atrial fibrillation, and a deteriorating mental status in a woman with Graves' disease who stopped her medication and caught an infection, with thyroid labs confirming thyrotoxicosis, though the storm itself is a clinical diagnosis. Your action: treat the storm, in order a beta blocker and cooling first for the immediate threat, then propylthiouracil to block synthesis, then iodine to block release but only after the thionamide, then glucocorticoids and supportive care, and treat the precipitant. And the outcomes you are steering toward: the adrenergic storm controlled, the temperature and rhythm settling, hormone synthesis and release both blocked, and the trigger treated. Recognize, analyze, prioritize, generate, act, evaluate. It was never about the number, it was about the fever and the rhythm. Now, the next patient. A woman who takes steroids every day for adrenal insufficiency, and who, sick with a stomach bug, stopped taking them for 2 days. Now her blood pressure has collapsed to 76/44, her potassium is high at 6.1, her sodium is low, and her blood sugar is low. Everything in you wants to work up each abnormal number on its own. But that exact combination, the low pressure, the high potassium, the low sodium, the low sugar, in someone missing her steroids, is itself the diagnosis, and the treatment cannot wait for a confirmatory lab. 6 decisions. That is case 208.